Hello.
Good morning, good afternoon.
Good afternoon. And just before the hour, I just wanted to check that my screen shares adequately. Would that be all right? I don't know if Prof. Verberg, you there?
I'm here, Jonathan. I'm sure you can do that.
I just wanted to just check that I've got no problems here with PowerPoint. Okay.
Okay, we see.
Are you guys seeing presenter view or normal view?
Proper view. Yeah, proper view.
Okay, great. That's fine.
Tell me, was this your title, or did you do it because you saw what our title is?
This was my title.
You're not serious.
Yeah, that's his original talk. Yeah.
Okay.
Here we go. Okay, great. So I'll stop sharing. There we go.
Do you want to go back, to that?
Hello, Justin. I see you also here.
Yes, I'm here. Hello, everyone.
Hi,
And,
Justin.
yeah, and Yusra. Hello, Yusra. So,
Hi, Yusra.
Well, you've already got 22 people on.
oh, that's cool. You know, it's the last session over here. We'll just see. So this is now the chatty part where we can say hi to everybody. Hi, Teresa.
I
Great
see
to
you
see
put four sessions into the one though.
What do you mean?
For the next 4 that are not here.
Say it again. No, we
You've got 4 talks, you've got 4 topics.
today, you mean?
Yeah.
Oh, it's terrible of me.
Not one of these is a small thing.
That you can say again, David. I've tried to get it into half an hour, but I may disappoint you.
We just, I think
Well, the good
it's,
news is I have a meeting at 6, so it has to be finished by then.
no, it has to be finished by 5:20.
Or should we start then?
We typically wait a little bit until there's at least sort of 30. So people are starting to come in. Yeah, it is actually the time to start. Sorry, I thought it was still, it's the right time to start. So let's start then. And let me just do the housekeeping beginning. So a very warm welcome from Cape Town to everybody. And it's great to see that there's still people who want to learn more about a transplant, even though it's December. And here in Kaapstad, it's already Slaapstad. Well, from next week, we'll all be scaling down. We're talking today about a topic that is extremely near to our hearts and precious to us, stem cell transplantation. And we've got 3 wonderful speakers, but first, let's introduce the chair. So I don't know if Khadine is giving me a chance to introduce him, but there he is. Great. So you want to go back to what's on the agenda, Khadine? So today we are going to talk about the history of stem cell transplantation, which we love. And then Cecile is also going to tell us about a new frontier. And then Jonathan is going to speak to us about our first transplant here. And then we go to a totally different area with multiple sclerosis. So, and then Justin is wanting to tell us about his local survey. So let's just get to Dr. Britton. He is the chairman of the biggest, foremost Pretoria East Netcare Transplantation and Hematology Center, the only center in Sub-Saharan Africa that's accredited by the international JC standards. And he has got a lot of interests in advancing the field of cell and gene therapy. We're not speaking of cell anymore, no, only stem cell transplantation or bone marrow transplantation, but we're now moving into the field of cell and gene. So perhaps he will also share a bit of that. So with that, I over to you, David.
Thank you. I think we must get rid of that picture. That guy looks like a smug bastard. Let's move on to the next slide. So we have a very, I'm not going to talk about my stuff today. As I said earlier, we've got four big topics to cover. We've got three superbly experienced and motivated, passionate speakers in their various topics. So I think we mustn't take up too much time on that. I think I know you. Okay, so firstly, we've got Dr. Cecile du Toit, who is a hugely experienced transplant physician at Cape Town, University of Cape Town, Groote Schuur, and has been part of the growth of stem cell transplantation in South Africa almost since its inception. And she's going to give us a nice run through of the history, and I'm sure show what we all know, that is stem cell and hematology is at the forefront of many medical developments and is probably going to stay there with the accessibility of blood and marrow for studying and growing cells, etc. I'm not going to introduce everybody now as you suggested. Am I? Okay, I am going to introduce everybody now as suggested. Following Dr. du Toit, we're going to have Dr. Oxley. Jonathan Oxley is the young blood, but already a sizable bit of experience in both academic and public health under his belt. And he is going to lead us through a case presentation at UCT of the first HIV positive donor transplant. And then following that is Justin du Toit, who also ex-UCT and has moved up to the big smoke and works in private practice at the Donald Gordon Medical Center, and has already acquired a nice little series of multiple sclerosis patients who've been treated by autologous stem cell transplant. A very exciting area of transplant medicine and immunology, with great results, and I think you will go through that. And to finish that off, he's going to present a proposal about the EBMT survey. I think we are very tight for time, so I'm going to push through and ask everybody to motor through their talk, but that doesn't mean we don't want to have participation and discussion. So at the end of every talk, we will have a short question and answer period. And so please put your talks into the chat box so that we can, facilitate and coordinate the question so that we can sort of pick the brains and experience of this excellent panel from today. So without any more fuss and drama, let's go straight to Dr. Cecile du Toit and your presentation, Cecile. Thank you very much for sharing today.
Okay, can you all see my screen in the proper view?
We can, thank you. Or at
Right.
least I can.
Okay, right. So thank you for the organizing committee for inviting me to speak on this talk and topic, which it is close to my heart, as Estelle says. And the topic then is historical milestones in hematopoietic stem cell transplantation. And towards the end, I will talk about one specific newer milestone, and that's also offering allogeneic stem cell transplant to patients with HIV. Right. The interest in doing bone marrow transplantation started in the 1950s, and there's a few good reasons for that. Kidney transplants were very successful, so transplantation was something that the medical community was thinking about. It was 10 years after the nuclear bombs in Japan. There was concerns about more nuclear attacks, nuclear reactor meltdowns, etc. And the hematologists realized they really had nothing to offer for these devastating bone marrow failure cases. And there was the hope that maybe, as they called it, humoral factors or the cells from a donor marrow might help after radiation injury. There was also very little to do for patients presenting with other hematological conditions of bone marrow failure, like severe aplastic anemia or patients with SCID, and very little to be done for acute leukemia. Some investigators were actually proposing at that point that they should treat acute leukemia with controlled radiation, try and destroy the leukemia, and rescue the patient with infusion of marrow cells. With all this in mind, the basic scientists came in with their animal studies in the laboratories, and the first was the very well-known study by Jacobson and colleagues proving that mice were protected from otherwise lethal whole body radiation if they shielded the leg or the spleen so that there were cells to repopulate the marrow. Main and Pren did similar studies, but they infused a marrow from mice of different strains and proved the engraftment by acceptance of skin grafts from that donor strain. Barnes and Loititz showed that transplanted spleen cells in mice have an anti-leukemic effect. Similar work was also done by von Beckham in the baboon model of transplantation. These two groups in their work were the first ones that described the wasting or secondary disease with skin and gut involvement and liver problems post the allografts. The term graft versus host disease was apparently first used by Barnes's group, and these researchers only called the condition that when they had become themselves convinced that the donor's immune system actually caused these findings. There were also various other animal models, the famous dog model from the Seattle group, and murine models in various centers, among them George Mattei Center in Paris. Studies in these animal models proved certain concepts that would eventually be helpful in bone marrow transplantation in humans. It was clear that when you did an allogeneic bone marrow infusion after radiation in an animal, there were three possible outcomes. Either the marrow would recover and the animal would be perfectly well, or the marrow would be completely rejected, or there was marrow recovery and secondary disease, or so-called graft versus host disease. It was clear that allogeneic bone marrow grafting is going to be unique because you were transplanting a viable new immune system with the possibility of bidirectional rejection. It also became clear that you would require tissue matching rather than blood group matching to select your donor, and that you would indeed require a preparative regime that must be very immunosuppressive enough to allow engraftment. With all this knowledge, it should have been the time to move towards human bone marrow transplant. But of course, the one big thing missing was the ability to do tissue typing. Don Thomas and his team in Seattle are credited with doing the first human transplants of bone marrow in 1957. 2 patients with advanced ALL received TBI conditioning and were infused with bone marrow cells of the identical twins. Engraftment, as expected, was good, but unfortunately death was due to early relapse. But the Seattle team stuck to their guns that they were not going to transplant from any donors other than identical twins till there was possible tissue matching. The French team by Mattei did not wait for tissue matching. Mattei and his team are credited for doing the first bone marrow transplants for bone marrow failure due to radiation exposure. And this happened in 1959 when they infused unrelated donor marrow cells in 4 of 6 scientists with bad radiation exposure at a nuclear reactor near Belgrade. All 4 had temporary engraftment of the donor marrow, followed by late autologous reconstitution, and they all 4 were long-term survivors. Matei is also credited by the Blood Journal for publishing the first paper on a sibling transplant for acute leukemia in 1965. The patient was a young doctor with ALL in remission after steroids and single-agent chemotherapy. Conditioning was with total body irradiation, and Matei infused bone marrow cells from all 4 siblings and the parents in one bag. Acceptance of a skin graft showed that the marrow of one of the brothers had engrafted. Matei, being as usual way ahead of his time, and at this point probably 30 years ahead of his time, was concerned about the lack of graft versus host disease, and that would predispose the patient to relapse. So he gave the patient additional infusions of white cells from the donor to enhance the graft versus leukemia effect, and called this treatment adoptive immunotherapy. This treatment was only used further in patient care about 30 years later. The patient never relapsed, but sadly died 20 months after the DLI of disseminated varicella. Now, this just shows the paper that you can go and read in Blood. And it's really very interesting read, amazing to read if you think you're reading a paper from 1965, how forward-thinking that team was. By 1968, it was 10 years of bone marrow transplants, and they analyzed the results, which was absolutely terrible. Out of the 203 patients transplanted with a preparative regimen, only 3 survived, and then there were the 4 survivors from Matei's initial transplant that did not have conditioning regimen. Causes of death included graft failure, graft versus host disease, and relapse, and many investigators were so discouraged that they absolutely wanted to leave the field. This very interesting photo actually shows some of the top investigators meeting in 1986, with here on the far left, Matei, next to him von Beckham, who studied the baboon model of transplantation, and Don Thomas. Fortunately, serological HLA typing became available in 1970 and obviously gave new momentum to this treatment strategy of bone marrow transplantation. The first transplant from an HLA matched sibling was done in the Seattle unit for a CML patient. Remember, this was way before TKIs. There was good engraftment, but sadly, this patient contracted CMV disease and died on day 56 of the transplant, showing one example of these unexpected complications that the initial pioneers encountered in doing bone marrow transplantation. In 1972, the first 4 transplants for severe aplastic anemia was done in the Seattle Center, and this was the first time they used their newly devised conditioning regimen of high-dose cyclophosphamide at 200 milligrams per kilogram, which is still their current conditioning regimen. 2 of these patients were long-term survivors, and not long after, the unit added ATG to this conditioning regimen. By 1975, they had already done numerous transplants and published a large number of papers detailing their experience. The 2 papers of which I'm showing the titles here were a 2-part review paper on transplantation guidelines, their experience, etc. It was published in 2 consecutive issues of the New England Journal in 1975, and is well worth a read if you can get hold of it. I must say I would like to read it myself again. Further developments in the 70s included the addition of cyclophosphamide and total body irradiation, as we still use it today, to the conditioning regimens. Graft versus host prophylaxis was now with methotrexate alone till 1978, when cyclosporin became available, and treatment for graft versus host disease was first-line steroids and second-line ATG. What about South Africa? In 1972, Professor Peter Jacobs became the first head of hematology, the big hematology unit at Groote Schuur Hospital. And because of stem cell bone marrow transplantation, being really in focus at that time. He immediately, from the beginning, working in consultation with Don Thomas, decided to plan to do transplantation in the unit. They started researching, got a team together and devised a rabbit model. And the first allogeneic transplant was done at Groote Schuur Hospital in 1974. So a long time before I arrived, if I think what Dr. Britton had said. Stem cell transplantation in the 70s to continue. The offering of transplantation to patients with severe aplastic anemia meant that probably between 25 and 30% of the patients were getting a transplant. So now it identified this huge unmet need for patients who did not have a donor. And two researchers, Matei, who we know well, and Spark, working independently of him, both noted that when they did transplants for severe aplastic anemia and there was graft failure, those patients who had had horse ATG during the conditioning very often recovered their own bone marrow. This led both of them to propose that horse ATG could be the standalone treatment for patients without a donor, and was the start of immunosuppressive treatment for aplastic anemia as we know it today. The 1980s saw various further developments. There was the improvement of prevention of CMV and pneumocystis. Oral busulfan and cyclophosphamide, the well-known Bucy, became an alternative to cyclo-TBI. Hemoglobinopathies also became an indication for transplant, and T-cell depletion with various strategies was being used to prevent graft versus host disease. This was obviously long before the TKI era, and one of the big problems in CML was the fact that only a small group had donors and a further group responded to interferon. So there was a large group of CML patients literally waiting to die of blastic phase. So finding alternative donors for them was a big unmet need, and there was an increased interest in using match unrelated donor transplants for CML already in the late 1980s. More patients were recruited to more donors were recruited to registries like Anthony Nolan and the NMDP with a view to doing match unrelated donor transplants. But it has to be realized that early match unrelated donor transplants at that point were done with serological typing only, and we can all imagine what that entailed. Obviously, there were some patients that were fine after the transplant, but there was an extremely high risk of either total graft failure or fulminant graft versus host disease. It was, however, considered justified in CML without a donor who failed interferon, as those patients were literally waiting to die of plastic phase CML. This is the point to highlight the huge contribution made by John Goldman at the unit of Hammersmith Hospital in London to all parts of the treatment of CML. He was the first transplanter in Europe to have a dedicated unit for CML, where he initially established a highly successful sibling donor transplant unit in the late 70s, early 80s. And he followed that with the, now, as I mentioned, the MUD donor transplant program for CML, initially under very difficult circumstances. He was also involved in establishing the Anthony Nolan Bone Marrow Registry in London and remained their medical director till 2010. It's very interesting to think that he was later on also part of the team with Brian Drucker and Novartis who developed imatinib. Now, all these new donor registries and all the transplant research and leukemia research would cost a lot of money, and in Europe at least, the José Carreras Foundation was able to supply a lot of funding. Now, those of you who are opera lovers, and maybe even others, would know that José Carreras was later to be one of the famous three tenors. Now, he was diagnosed with ALL in 1987. He had no family donor, and there was barely a Spanish registry, so they could find no donor for him there. And he then went to Seattle, where he had a purged autologous transplant for ALL, and interestingly enough, was actually cured. In the top photo, he is pictured with the Seattle team at an opera recital a year or so after he's discharged from the transplant. Here to his immediate right is Don Thomas. Now, following his transplant, Carreras dedicated the rest of his career to collecting funds for his newly established foundation, which was initially established just with the aim to create a donor registry in Spain. But the foundation was so successful that it ultimately funded registries in other countries and a huge amount of research grants for research in leukemia and bone marrow transplantation. And to this day, it funds leukemia research and transplant research in Europe and the United States. In the bottom photo, he is pictured with the three tenors, all funds that, money that he earned from the three tenor concerts and the CDs and DVDs went to his foundation. But what hematologists often don't realize is that all money that Pavarotti earned from all the three tenor concerts went to thalassemia research. In 1990, Don Thomas was awarded the Nobel Prize for Medicine for his contribution to bone marrow transplantation. In the early 1990s, there were two buzzwords: graft versus leukemia effect and donor lymphocyte infusions. Obviously, now going back to what Mateo already did in 1965. The Hammersmith Group, with their specialist transplant center, proved that there were early relapses in CML patients who had T-cell depleted grafts, showing the importance of a graft versus leukemia effect in CML. In 1990, researchers like Kobe in Germany and Simon Slaven in Israel postulated that one could maybe prevent and treat the relapse of CML after transplantation with so-called adoptive immunotherapy using donor lymphocyte infusions. For those who are not aware, these early donor lymphocyte infusions were rather crude and rather dangerous in the sense that they often infused a single dose of donor lymphocytes as high as 1 × 10⁸ or even 1 × 10⁹ CD3 per kilogram right up front. Fortunately, donor lymphocyte infusions were refined and made safer by the proposal of Steve McKinnon to do graded incremental dose infusions as we use today. The 1990s also saw the advent of very importance of peripheral blood stem cells, and by the mid-90s, all autologous harvesting was now being done with peripheral blood stem cells. And since the mid-1990s, there's been a gradual increase in the use of peripheral blood stem cells for allografts. At this point, obviously, currently the majority of adult bone marrow harvesting is done with peripheral blood stem cells, but in children, we all obviously still prefer bone marrow harvesting. There was also an increased use of cord blood in the 90s. 2000 plus, we all know what happened as we lived it: high resolution tissue typing, various intensities of conditioning regimens, and the advent of haploidentical transplants. The initial strategies like using CD34 selection did not prove very successful with quite poor outcomes, but fortunately the PDSI strategy of Baltimore and the ATD strategy from the Chinese resulted in improved outcomes and the huge increase in the use of this strategy. Going back to Georges Mattei, just before his death in 2010, he received various awards, and among others, he was honored by an award for doing those 4 stem cell infusions for the patients with the radiation accidents. And here was a plaque commemorating that, and standing next to him is actually one of the survivors of that radiation accident. Now, at this point, I just want to pause in my talk and say that all of us who are transplanting now do owe these pioneers a great debt of gratitude. I mean, we take it for granted that we have guidelines and protocols and that we can read up about what we do. They went blindly, and almost with each transplant in the beginning, they encountered new surprises and complications that they had to deal with. For the next part of my talk, I'm just going to talk about one of the newer milestones, and that is the ability to offer stem cell transplantation to patients living with HIV. We all know that since the advent of antiretroviral therapy, autologous transplant has become standard of care as part of the salvage of HIV lymphomas, but there has not been that much progress in allogeneic transplants in HIV. There are two aspects that are of interest in allogeneic transplants for HIV positive patients. The first being to do it for the specific hematological indications, and the other being the theoretical chance of cure of HIV if you have a donor who happens to be homozygous for the CCR5 delta 32 allele. Looking in the literature, there were reports of allogeneic stem cell transplant in HIV positive patients as early as the 1980s. Not surprisingly, there was a very poor response in these patients before effective ARVs was available. And of the 14 cases reported before 1996, only 2 were long-term survivors. More recent data in support of allogeneic transplants in HIV comes largely from small center retrospective studies. A small analysis of the cases published from 2000 to 2017 revealed 49 cases in the literature, including one small prospective study from Spain that included 17 patients. This pie chart shows the indications for these transplants, and we can see that by far the majority of patients were transplanted for acute myeloid leukemia at 41%, and the next group was ALLs at 9%, and then various other indications for transplantation. From the literature, we see that allogeneic transplants in HIV is a reasonable option for patients who meet the standard criteria for their specific hematological condition, provided
5
the
minutes,
HIV...
HSCT.
Hello? Oh, 5 minutes.
I
Okay.
say 5 minutes. Sorry
no, I'll be done.
Yeah.
I'm very nearly done. The HIV must be controlled, and the patient must have adequate organ function, and just understand that having a donor with the CTR5 delta 32 does not mean cure. How does cure happen? Basically, 2 important aspects. You have to deplete the reservoir of HIV, which is the immune cells in the host, and that is done by initially being virally suppressed, as well as the conditioning regimens, the radiotherapy, the biological agents, and the graft versus reservoir effect. Depleting that reservoir does not eradicate the virus, and if you stop there, the virus will just reactivate. What you also need is stem cells resistant to HIV. The only way so far to successfully achieve that is that the donor must be homozygous for CCR5 delta 32, but there must be 100% donor chimerism to achieve it. I just want to briefly introduce you to 2 patients that are known to be cured. We all know the Berlin patient, Timothy Brown, or the late Timothy Brown. Just interesting for us to know a bit more about his hematology. He had developed AML in 2005 and refused a transplant, and it was only in CR2 in 2007 that he was then transplanted from a donor with a mutation. His ARVs were stopped. He sadly had another relapse, transplanted from the same donor, and then remained HIV negative till his death of AML in 2020. So he was HIV negative for 13 years post-stopping ARVs. The London patient was the second patient known to be cured of HIV. His hematological history is extremely interesting in the sense that he was diagnosed with stage 4B Hodgkin's, refractory to ABVD, only a partial response to ESHAP and brentuximab, eventually in remission after IGF. Autologous harvest failed, and then he had a mud transplant with a donor positive for the mutation. For us, also of interest, he had T-cell depletion with intravenous Campath. And since 2016, he's been off ARVs and remains HIV negative. At this year's AIDS conference, it was announced that there are now 5 patients considered cured, including Timothy Brown and Adam Castillo. There is also the Düsseldorf, the New York, and the City of Hope patients. And with that, I thank you with wise words from Don Thomas. Right, any questions?
There are no questions in the chat, but thank you very much for a very thorough run through the history and some of the sort of landmarks of transplant immunology. I think that is something that I also often say to my patients is that, you know, the drugs have got side effects, but nothing makes you feel worse than your cancer not being controlled. And I think that is a very true and valid point. I don't know if there's any, I haven't seen any more questions in the chat. And my earlier note was not to say that you've been there because you're so old, but that you have been there through so many parts of the evolution and have been so fundamental to the evolution of stem cell transplantation in South Africa.
Yeah,
so
no, I do understand, but considering the first one was in 1974, I was still in primary school, fortunately.
Exactly.
Just teasing you. Right, thanks.
Thank you very much for that. I think and there may be some other questions that come along later, but due to time being a bit of a pressure, we're going to move on with Jonathan to his case presentation. Jonathan, the floor is yours. Beautiful slides so far that we've seen.
Great, I'm unmuted, I hope, and from the start, there we go. Okay, thank you very much for the opportunity to speak at this deep dive. I've entitled the transplant, the talk, Transplanting in New Territories. And essentially what I want to do over the next 15 minutes is very briefly take us all through a very interesting and landmark
Sorry,
case.
Jonathan, I'm not seeing your slides. Are you sharing them? Has everybody else seen them?
No.
Okay, sorry about that. Let me go to, I thought I was on share screen.
You're also welcome to put on your own video if you want to.
Okay. Oh, thank you. I think I'll just, am I winning so far?
Yes.
Is my
much better.
Okay.
Thank you.
Is that better? Fantastic. So what I want to do over the next 15 minutes is just take us all through a very interesting and landmark case that we managed at our transplant unit at HSCT. And I'm going to dive right in because of time reasons. Our case revolves around Mr. SG, who is a 37-year-old male from East London. He's a school teacher, and he's got a history of smoking and drinks regularly on the weekends prior to his transplant. He's got a background medical history of HIV diagnosed in 2015, and he was doing well in his antiretrovirals. In 2020, he was switched to a dolutegravir-based regimen. And in March 2022, he had a suppressed viral load, but a CD4 count of only 240. And he complicated with this impaired immune system in 2020 with the development of first pulmonary tuberculosis and then TB meningitis. He was treated for 9 months and thankfully had a very good neurological outcome. So he initially presented with a hematology problem in November 2021, when he went to his local hospital in East London with features of severe symptomatic anemia. His initial full blood count showed that he was pancytopenic with a white cell count of 1.5, neutrophils of 0.65, ATB of 3.3, and platelets of 6. And so he was treated at that hospital with multiple transfusions for several months and was eventually referred to Port Elizabeth for further hematological workup and treatment. And eventually got to PE in March 2022, where he saw the hematologist in Port Elizabeth. And at the time of arrival in PE, he still had features of symptomatic anemia, as profoundly pancytopenic. On examination, it was noted that he was exceptionally tall, 1.97 meters. And also of note is he had one large cafe au lait spot on his back. The rest of his clinical examination was unremarkable. On infective blood workup, it was noted that he had syphilis, and due to his low platelets, he was given 2 weeks of doxycycline instead of IM injections. So this is what his bone marrow should have looked like for his age, but unfortunately, this is what it looked like. And what was striking there is that he had a markedly hypercellular bone marrow with fatty infiltration, and there were no blasts on his marrow, no features of a hypercellular myelodysplastic neoplasm. His PNH flow cytometry was negative. Fanconi's anemia studies, which despite his tall height was something that was thought about because of his cafe au lait spots, was negative. And on further history taking, it was noted that he had no drug or toxin causes. And so the thought was that he had severe idiopathic aplastic anemia. So I just want to run through briefly the classification of aplastic anemia. It can be congenital or acquired, with Fanconi's anemia being the most common congenital cause. Other causes such as dyskeratosis congenita and Schwann-Diamond are also known congenital causes. But then most causes are acquired and usually idiopathic, with autoimmune or viral drivers driving the condition, but toxins and acquired clonal disorders such as PNH also to be considered. So in terms of the management, just an overview, generally supportive measures involve transfusional support and antimicrobial prophylaxis. But then really the decision is whether to transplant or to not transplant. And that revolves around three main questions. What is the patient's age and performance status, and whether there's a donor or not. And so generally younger patients that are fitter lean towards transplant, whereas older patients or more frail, or if there's no donor, lean towards immunosuppressive therapy. So our patient was referred to HSCT for an allogeneic stem cell transplant. But this was no ordinary transplant for us, although we've done many allogeneic stem cell transplants for aplastic anemia. We'd never done one in a patient with HIV. And so this was definitely new to us, and to the best of our knowledge, new to the state sector in South Africa, although we have heard reports that it has been done in private. What made this important is that we had to take a step back and look at some important considerations and challenges. And what I want to do during the rest of my time is just look at 5 key considerations and challenges that we faced as we went through the process of considering transplanting this patient. So the first one is that this is really new territory for us at HSCT. The role of autologous stem cell transplant is really well established in HIV-related lymphomas, with outcomes that are comparable to HIV-negative patients when it comes to treatment of their lymphomas. This is in contrast to allogeneic stem cell transplants, where there's only been a handful of studies and case reports that describe the use of this method of transplant in HIV-positive patients. And these are usually single-center studies that are retrospective with very small patient numbers. To make things even more complicated in our case was that there are even fewer cases where there's an HIV patient that has aplastic anemia that is going to get an allogeneic stem cell transplant. And we only managed to find 4 such cases, none of them which use the technique of Campath in the bag that we use. The second big challenge was that this was a complex patient. A quote from a really good article that I've put a picture up under the quote, how I treat patients with HIV-related hematological malignancies using hemopoietic transplant, says that patients need to have an evidence of treatable HIV infection and adequate end organ function. So how was our patient meeting up to that? Well, on the positive is that he had a suppressed viral load on his antiretrovirals, which was great. But the downside is that his CD4 count was not high at 260. And he had a recent episode of TB meningitis, although fully treated, spoke to his immunodeficiency. He also had liver dysfunction. When we reviewed his notes, he had long-standing transaminitis, with ALTs ranging from 200 to 400 for the previous 12 months. They would just fluctuate. We actually involved our liver team, who really turned the patient inside out and asked many questions. We found out that he had subsequently stopped all alcohol binges, that his viral studies were negative. What we did notice is that he had some iron overload. His ferritin was approximately 1,500, likely due to the many transfusions that he had received, over 50 red blood cell transfusions prior to his referral for stem cell transplant. But this was unlikely to fully account for the liver function abnormalities at that level. The other thing that was of concern, also related to transfusions, was the burden of transfusion this patient had received. So if you take 50 red blood cell transfusions, that's 50 donor exposures, plus 20 platelet transfusions, which were probably pooled platelets, many of them having up to 10 donors in them, that's a huge number of donors that he has been exposed to, over 200 donors. The third challenge was drug interactions in this case. And so the era of antiretroviral therapy has really been a game changer when it comes to overall survival for HIV allo transplants. As Dr. Du Toit mentioned earlier, in the pre-ART era, the overall survival for these patients was in the region of 12%, whereas in the post-ART era, it was up to 44%, and this was with the use of antiretrovirals that were far more toxic than the ones we have today. So there's several serious interactions that need to be considered when using ART, and this is with the conditioning regimens that we use, such as fludarabine, with immunosuppressants, such as cyclosporin, cyclophosphamide, and the antifungals that we use. Specifically, the protease inhibitors are culprits, and thankfully we don't use them in the age of dolutegravir much anymore, but there are significant interactions with the protease inhibitors. AZT in general should be avoided if possible due to the hematological effects of this drug. And thankfully, as mentioned, we've got integrase inhibitors, specifically dolutegravir, which have a favorable interaction and toxicity profile. Ideally, antiretroviral should not be interrupted through the transplant period. There have been reports of patients that have interrupted their ARVs due to mucositis, for example, and unable to take oral treatment, and have had a clinically significant HIV viral load spike, even leading to a seroconversion-like illness. And so for this reason, some units that do these transplants use use non-myeloablative conditioning or reduced intensity conditioning. We used our standard conditioning for this patient, and thankfully he made it through problem-free. This is quite a busy slide, but it's just to highlight the protease inhibitors and non-nucleoside reverse transcriptase inhibitors, which have serious effects with many drugs that we use as standard in our transplants. The fourth challenge was the challenge of GVHD. So ideally, the stem cell source for non-malignant conditions should be bone marrow over peripheral blood, and this is due to the decreased number of cytotoxic T cells, thus conferring less risk of GVHD. However, this is not actually standard practice in many institutions, and for many reasons. One of them is that bone marrow harvesting, as we are soon to find out, we have one lined up, is logistically very difficult. It's also less comfortable for the donor for obvious reasons. And there's also a paucity of evidence that there's actually a benefit in HIV allos with aplastic anemia. Our practice at Critiscare is to use, for GVHD prevention, alemtuzumab, also known as Campath, which is an anti-CD52 antibody. And we use a strategy termed Campath in the bag, in which alemtuzumab is administered into the graft 30 minutes prior to stem cell transfusion into the recipient, thus causing T cell depletion. And then this is followed by post-transplant cyclosporin. Thankfully, there's no evidence that HIV-infected patients are at any greater risk of GVHD, but definitely something to consider, especially with the use of cyclosporin and some of the antifungals and ARVs that may affect their levels. And the next challenge is the infection risk in these patients, and these patients are at seriously higher risk compared to other patients of infection during transplant. Opportunistic infections are a major cause of mortality, and in the literature, what's really highlighted is the use of surveillance and preemptive treatment for CMV. Other opportunistic infections, such as PCP, herpes viruses and mycobacterium, it's important to cover them prophylactically. And in our case, due to our patient's previous TBM, we use INH prophylaxis post-engraftment and cotrimoxazole to cover for PCP and valacyclovir for CMV and HSV prophylaxis. So how did our patient fare in the end? Well, on the 8th of July, he was admitted into our unit for the transplant. Unfortunately, 10 days later, his liver profile deteriorated, and we suspected that fluconazole was the culprit. And so we changed that for mycofungin, and there was a moderate decrease in his liver functions, but never completely normalized during the admission. His 2 days later, he then developed neutropenic fever, and it was an ESBL Klebsiella. Thankfully, he responded very well to ertapenem. And then the rest of his transplant was uneventful, with engraftment on day 17, and he was then soon after that discharged from our unit. And his follow-up has been uneventful. We've been monitoring his cyclosporin, which has been therapeutic. The proof is in the pudding with the aplastic anemia, his white cell count improving on the 21st of October to 2.31 with neutrophils of 1.55, an HB of 10 and platelets of 120, stark contrast to his initial bloods. His liver functions have settled with an ALT of 78, and his chimerisms now show 100% female donor chimerisms, much to the alarm of our male patient initially. So could this possibly be a cure for our patient? And I'm not going to spend much time on this slide because of just our rush, but just want to highlight a few things. First of all, as Dr. Dutoy mentioned, there's 2 steps if you were to cure someone with an allogeneic stem cell transplant. And the first would be the rapid decrease in the HIV reservoir. And this is really due to 3 factors that act in concert: the conditioning versus HIV effect, the campath versus HIV effect, and the graft versus HIV effect. These all rapidly decrease the viral load, but to prevent these donor cells from becoming reinfected with HIV, you actually require the homozygous CCR5 delta 32 mutation. And without this, there's likely to be reinfection of the donor cells. So could our patient be the Cape Town patient from Eastern Cape? Well, unlikely, owing to the fact that his stem cell source was his sister, who's a matched sibling donor with the same CCR5 allele, probably, maybe not. We did test the patient's donor for the CCR5 delta 32 mutation. That test is still pending, but we think it's unlikely. The viral load is lower than detectable now, but he is on ARVs. Overall, we're really happy with his response. So what are the take-home messages? Well, in essence, first of all, this can be done in South Africa, and this is great as it provides a new avenue for treatment for our HIV positive patients that require this mode of transplant. Secondly, it's really important to consider the patient disease and treatment related challenges, specifically drug interactions, which are important to consider, as well as careful monitoring and prophylaxis for opportunistic infections. And then finally, this needs a multidisciplinary team. We had extensive help from our infectious diseases division, as well as the hepatology division, and really can't be done in isolation. We had to ask advice from many people, and it was really a team effort. So overall, it's a great milestone for Critiskia, and I think for the treatment of HIV positive patients in our country. Thank you.
Thank you, Jonathan. I think a very exciting case, and although, as you point out, there have been sort of some case reports in the country before, they're certainly not enough if you consider that a significant proportion of patients of the population are HIV positive, and that means that a significant proportion, just coincidentally, of young patients with hematological diseases will have HIV, and when you consider its role in the causative part, that's really also very important. Michael Pepper and Candice Hendricks just submitted a paper with a few other authors to talk about HIV positive donors as being a reasonable donor source, even in HIV negative patients. And I think that's a very provocative and exciting area. If you think that, to take Cecile's point of HIV, I mean, nothing is more toxic than untreated or uncontrolled leukemia, that this may well be an important donor source in a country where HIV is so prevalent and is able to be treated effectively. Just on the same sort of line, Michael Pepper has long had a passion for HIV and he has been actively involved in preclinical research to knock out chemokine receptors and so to do autologous transplants in patients for their lymphoma, and then hopefully at the same time cure them of their HIV. So these are, I know you make the point that it can be done in South Africa, but really it can be. I mean, this is where the problem is, and this is where, and we do have the technology and the science and the knowledge to be able to manage this. So I think that those are very important things to consider. I don't see any other questions. I'm surprised that you guys are also so mute here, because I think it really is an exciting and relevant area of medicine because of our huge HIV burden. So I don't know, Jonathan, if there's anything you want to add to that, or anybody else, now's your chance. Otherwise, I think let's move on to Justin, who is going to swing a little bit here, but at the same time, remember that it's also about immunology. Multiple sclerosis is an autoimmune disease, and the management of immune problems is very important. So Justin, do you want to share your slide deck, or will the host share the slide deck?
Yep.
And we can get on with that.
Okay, can you guys see my screen?
Now we see presenter view at the moment. There we are. We've got full view.
Okay, good afternoon, everyone. So Jonathan presented a new territory in allogeneic transplant, but as David Britton said, autologous stem cell transplant is also a very new territory in multiple sclerosis. So we decided to look at the autologous stem cell transplant outcomes at our center at Wits Donald Gordon. Now, first, you're going to ask me, how does this actually work? Autologous stem cell transplantation in multiple sclerosis, and it's very much immunology. So it's to reconstitute and to recondition the immune system towards a self-tolerant state by depleting the autoreactive immunological memory cells by your high-dose chemotherapy. And after this, it's followed up by regeneration of renewed and diverse immune cells, which effectively leads to an immune reset. It does lead to a wider or renewed T cell repertoire, specifically the CD4 T cells. And this improved diversity is actually associated with complete and better clinical responses. It also lowers the pro-inflammatory T cell effector responses by lowering the ROR and interleukin 17 mRNAs. And I mean, there's many studies with many other mechanisms being described. So why is autologous stem cell transplant gaining so much momentum at the moment in MS? So this is actually fairly recently published in JAMA Neurology, and they looked at all the different trials happening around autologous stem cell transplantation in MS. You can see there's about 4 phase 2 trials, but there's one very important phase 3 randomized controlled trial where they actually compared autologous stem cell transplant to conventional disease-modifying therapy. So that's what DMT stands for, and it's the MIST trial. So in this trial, they had about 110 patients, which is quite a big number for RCT. And what they actually showed was that there's confirmed disability worsening way more in the DMT group at around 66.7% versus just 5.8% in autologous stem cell transplant. Now, to look more, just a little bit more in depth at this particular study, so among the 110 randomized patients, mostly were female, 66%, with a mean age of 36. 103 remained in the trial, and 98 were evaluated at 1 year, and 23 evaluated yearly for 5 years. The median follow-up was about 2 years. Disease progression occurred in 3 patients in the transplant group and 34 patients in the disease-modifying treatment group. Median time to progression could not be calculated even in the transplant group because of too few events, but it was about 24 months in the DMT group. During the first year, the mean EDSS score, I'll tell you now in a short while what the EDSS is, actually decreased, or can say from a clinical point of view, improved, okay, from 3.38 to 2.36 in the transplant group, and actually worsened in the DMT group. There were no deaths, no patients who received transplant developed non-hematopoietic grade 4 toxicities. So their conclusion was, in this preliminary study of patients with relapsing remitting MS, non-myeloablative transplant compared with DMT results in a prolonged time to disease progression, although further research is needed to replicate these findings and to assess long-term outcomes and feasibility. So just to show you what the EDSS score looks like, and this is a really crude score, so it actually varies from 0 to about 10, and you can just see that the higher the number, the more disability you have, basically. Okay, then, so we embarked on a retrospective audit to determine the safety and feasibility of this procedure at our center. And we looked at the data between July 2019 and December of 2021, and we performed about 8 autologous stem cell transplants for MS here at Wits Donald Gordon, and we looked at patient demographics, the EDSS score prior to stem cell mobilization, the type of MS, the number of DMT therapies prior to transplant, the transplant mobilization strategy, the type of conditioning, engraftment of neutrophils and platelets, the progression-free survival, so that would be a improvement or deterioration of EDSS, and then post-transplant complications. So coming to the results, we only did 8 transplants. Most of the patients had a median age of about 43 in a range of 19 to 49. The majority, so 5 out of the 8 were female. The median EDSS score before mobilization was 2, but it varied from 2 to 7. And 4 out of the 8 actually received more than 3 treatments prior to transplant, versus 3 that received more than 2, and then 1 that received only 1 previous treatment. The MS subtype, the majority, 7 out of 8 had relapsing remitting. There was 1 primary progressive. The mobilization strategy, 1 patient was mobilized with cyclophosphamide and the granular colony stimulating factor, and then 7 had GCSF only. The majority, 7 out of 8, had the acceptable minimum collected, above 2 million cells. There was only 1 patient we struggled with, but it was above 1 million, and we continued with the transplant. And then you can see the conditioning type was half received cyclophosphamide, rabbit ATG, and Medrol, and the other half fludarabine cyclophosphamide. The median days to neutrophil recovery was 11, and to platelet engraftment was around 16 days. So that's what we would expect. Now, in terms of the EDSS score, and just note it was a subjective score, it wasn't objective, it was subjective, is that 5 out of the 8 actually had an improved EDSS score, 2 had a stable EDSS, and then 1 patient had a relapse requiring treatment. And the post-transplant complications, so this is within the first 30 days, 1 developed neutropenic sepsis requiring inotropes. 4 patients had neutropenic sepsis without inotropes, and then 2 developed hemorrhagic cystitis, and only 1 patient developed both neutropenic sepsis and hemorrhagic cystitis. And then within the first 100 days after transplant, one patient developed CMV reactivation zoster, and there were 2 bacterial infections noted, but not serious infections, easily treatable, and we had no fungal infections. Our treatment-related mortality was 0, and the overall survival is 100% respectively, but with a median follow-up of 20 months and the range of 2 to 30 months. So we could confirm the safety and feasibility of transplantation for MS patients at our center. The improvement in the EDSS score in most patients is encouraging. However, the follow-up time is short. And I just want to thank you, my colleague, Dr. Thompson, Devin Moodley, that also shared some of his data, our intensivist, Dr. Tilly, and then with his colleague, Dr. Bertelman, and then also Professor Lundgren. So the next step would be is to do a bigger retrospective analysis by combining autologous stem cell transplants for MS from Dr. Moodley over the last couple of years, including David Britton's cohort of patients with ours. And I hope to present this in the future soon, so watch this space. And with this, and with growing research abroad, we hope that we can actually convince the funders in South Africa to fund the autologous transplants, because at the moment it's all self-funded. The medical aids do not cover this particular procedure, which is quite sad. I just want to share some certain caveats around how to manage these patients, which you should not forget when they're in your unit, is that the supportive care is quite different, okay? And it makes a huge difference. Because the MS patients get bladder dysfunction, you have to catheterize them when they enter the unit, give them a lot of fluids, and of course, Mesna is important with the cyclophosphamide. You have to give them seizure prophylaxis. We often use Keppra. And when they do get fever during the neutropenic phase, you have to treat the fevers very quickly, because if it persists, that it can actually worsen their long-term disability, which is called the Untoff phenomenon. So just remember that you have to treat the fevers and the infections just super quickly. And then, of course, planned rehabilitation ahead. We're lucky to have a physiotherapist that actually starts with the patients on the day of admission, because they do decondition way more than just a patient that doesn't have MS. And then, of course, very interesting and very important is that they have to undergo like a pre-transplant washout period of the DMTs to optimize stem cell mobilization, because it can affect your stem cell collection. And I'll go through the timelines now. And then, of course, early post-transplant follow-up is extremely important to prevent all sorts of infections, especially viral infections like CMV, EBV, and zoster. And then lastly, do not forget about the transplant vaccinations in this particular cohort of patients. So just to mention the washout periods, it's about 6 weeks for dimethyl fumarate, fingolimod, and natalizumab, and 6 months for alemtuzumab, ocrelizumab, and cladribine. You can get an accelerated washout period with activated charcoal for teriflunomide. It lasts about 2 weeks. And then there's no washout necessary for interferon and glatiramer acetate. And then, of course, a big important question is, who do we actually transplant? I think this is very important, because this is suggested by the EBMT guidelines currently. So we only transplant relapsing remitting patients with high clinical and MRI disease activity. The EDSS scores should be less than 5.5. They should be younger than age of 45, and the disease duration of less than 10 years. So that's level 1 evidence. Although patients with aggressive MS who develop severe disability in the previous 12 months, you can also consider to transplant, although the evidence for that is a little bit less robust. And then autologous transplant should be delivered in a JC accredited unit, preferably, due to the high quality of care and quality management. Of course, that's a challenge in South Africa. And then units should be experienced with close collaboration between transplant and neurology specialists, but to be honest with you, neurology specialists, that would collaborate with you on this particular field is as scarce as chicken teeth, as I would say. Anyway, then I just want to show you this one particular patient, and this is what inspires me to continue this type of transplant. So this is a patient of mine, and just to say, she gave me consent to share this with all of you, and she actually sent me the videos to share. So I'll share it with you. I'll just show you what she looked like on the day of admission. Just note she could not walk at all. Sorry. So she came in the day for admission. And then this was 3 days post-transplant. This is our neuro physio who's there. Could see she was quite still very weak in the legs, still a bit off balance, but the positive here is that she could actually move her limbs. When she came into the unit, she could not move her limbs at all. Okay, and then I'll just show you when she was discharged from hospital. She was so happy, but she could walk with a walker. And then I want to show you this last video, which she is 6 months post-transplant, and she can walk unaided. She said to me that she could plant her own plants now, and above all, most importantly, her hair grew back. So, yeah, so this is what really is amazing in this particular field at the moment, is that autologous stem cell transplant for MS can do so much for the patients. And I think we must continue to convince the funders to fund this type of transplant. And I hope that we can use research in order to answer that question. Okay, so now I can stop sharing. But I just wanted to ask, David, shall I continue with that link?
What's the time now? Yeah, I think so, because we're running out of time. I think you've covered some very important parts there, and I know Charlene is about to embark on a clinical trial for this as well. And I just wanted to make the point, though, before you move on to your EBMT thing, that this gives patients that have MS are usually confronted with like, well, this is a hopeless situation and that you're going to just deteriorate over time. And for the first time, you can actually offer them something positive to look forward to. And fixed neurology will not revert. But if there's inflammatory changes, that's always the balance is, some people have one attack and then they don't have anything for years afterwards. But for a person who's got active disease, this is a very effective therapy and way more effective than the current treatments and way less expensive than the current disease-modifying therapy. So I think I think it's a really important thing, and anybody who's got cases should perhaps share them with you so that you can put together a nice big case load. Estelle, you wanted to ask something?
Yeah, I was just wondering, there are a few questions I see apart from mine. I invited Prof. Bridget Hodgkinson. I don't know if you want to put on your video, Bridget. She is a rheumatologist in our unit, and I could not find a neurologist at this time of year. But Bridget, I think it would just be nice to hear your response. What do you think of this type of thing, and what would you like to see in your field?
Yeah, you're on mute.
You're on mute.
That's better.
Thank you, Ms. Ma. Thank you, Estelle, and thanks to all the speakers for a really interesting meeting. and fantastic results, Justin. And I think that I think we must look at putting some of our systemic sclerosis patients into the program. How much does this whole thing cost if it's self-funded?
Bridget, you know what? We just had one patient now we transplanted with scleroderma.
Yeah.
There's a famous rugby player, and he's done really well. But this is not so expensive. I think the transplant is around, oh gosh, it's probably 150,000, I would say. Yeah.
Yeah, great. Exciting times.
Now, the problem is if they have complications, that's actually the real cost. So, but we've also had some success with the scleroderma. I think the important parts there is to make sure the heart's okay before you start. And also the expectation, it takes a long time for the scleroderma to reverse. You know, you see ongoing improvement for a year or even 18 months as the collagen mobilizes. I'm not sure.
Neuromyelitis optica, is that something that anybody has come across? I mean, because that's
there's very little data on that, and except for the patients that progress to MS, I think that it's a bit difficult to justify that. But the one part that does justify it is that, you know, you only have two eyes and they're very important, and if you've lost one, then maybe that is an indication to do that. But there are, I mean, treatment with the rituximab and other immunosuppressives is probably still the standard there.
so. Just from my side, thanks, Bridget, for weighing in, and let's hope there is a lot of activity in this field. It seems to be a very viable and doable treatment. Oh, back to you guys. Sorry.
Okay, Justin, I think you want to go ahead with your survey.
Yes. So, okay, just wait for me. I'm almost there. So I just want to say, I'm going to share a very important link, guys. Now, this link is just, it's going to take you 3 minutes, okay? And what I propose to do with this data is to present it at the EBMT next year, April, okay? I'm going to present it at the trainee committee meeting. And what we're trying to do with the trainee committee meeting at EBMT is try to get different countries involved across the world in order to get funds to get fellows or trainees to be funded to go to the transplant course at EBMT or somewhere in Europe, and also to go to the annual meeting actually. So this is why this link is so important. So I would really urge you, please fill it out for me, that I can create data in order to show them that our fellows need more education, because that's solidly what I believe. And I'm hoping that next year, and that's why Estelle asked me today to say that there's going to be a lot of new things coming for the new year in terms of the BMT classroom that happens every Wednesday. We're having case discussions. We're hoping to do a journal club as well. And then, of course, basic topics on transplantation. So yes, all I can say is that watch this space, and I'm hoping that this platform will grow bigger. And please fill out this link for me. I'm going to put it in the chat box. And let me just see if it works. Okay, can someone just click on the link for me and see if it works, if it's possible? And please fill it out for me that we can create data in order to get funding for our fellows, please.
Works for me.
Okay, perfect. So if it works, then we call it a day. And thank you for the opportunity to speak on this amazing platform, guys. Thank you.
Okay. So I think it just remains for me to close up and to thank all of our speakers for sharing their experience and for working so hard to prepare their talks and their patients. So, and thank you to Estelle, to Blood SA, and Deep Dive for a year of superb talks that have maintained our interest right up until the end, with a huge number of participants every week. Well done to the fellows that wrote their exams this year, and we look forward to seeing you in, shall I say, the real world, but then that's a bit provocative. But we look forward to seeing you wearing your colors proudly. Thank you again to everybody for a fantastic year, and we will see you in the new year. When is the first one next year, Estelle?
We haven't finally decided, but probably the 9th or the 16th, probably the second week.
Watch your emails after New Year's and put it in your resolution box, okay, guys?
And let's see if we can do some new things together. So it's great to work with everybody, and thank you, everybody. So have a lovely year end, and have a good rest.
Thank you. Thanks, Estelle. Thanks for all you did this year.
Thank you, David, for being with us, and thank you for leading us in transplant. And yeah, thank you for our external speaker, Justin. It's great to have you with us again.
Good night.
Yeah, goodbye, everybody.